Recording right now, and the beginning of the recorded portion of the webinar starts now. Michael McGowan is a former state CMS region OASIS coordinator, and he's the president of OperaCare. And experience from CMS taught him to data mine OASIS data points, and he supported CMS's survey and certification data-driven survey protocols. And this guided state surveyors to condition level deficiencies and terminable situations in California's 700 plus home health agencies. He realizes that agencies aren't committing fraud. They're rather, agencies don't realize that their OASIS documentation is causing red flags that are easily identifiable by CMS contractors. And often home health agencies only discover they're out of compliance after the fact. So his knowledge of this information helped him lead to the development of OperaCare. It's an automated compliance census management quality assurance software that facilitates the live interactive QA during the OASIS assessments that we just talked about a moment ago. So I'm very excited to introduce Michael. And Michael, I'll go ahead and turn the presentation over to you, and we can begin.
Sounds like a plan. Thank you, Robert. It's a true pleasure to be here with the DeBarrow team and to speak about the forthcoming changes that we're about to see in basically the entire nation. So as I'll get going here, I think all of you will soon see your 5-star ratings are a very good beginning, but they're not going to be nearly enough for the long haul. The long haul being 2, 3, 4 years down the road. The new alternative payment methods and models that are being introduced are going to require the re-engineering of all of our business structure and functions. This will happen just the same way it did in the acute care reforms and as the acute care reforms had changed the hospitals. The hospitals used to engage in a high volume, large bed capacity model, and home health providers who are currently engaged in a high volume, large census, low value care model to CMS will soon be replaced with a high acuity, outcomes driven, rapid cycle care model. Again, this is going to mimic the restructuring of the hospitals. Thank goodness we have the examples of 20 years worth of innovations in our acute care hospitals, skilled nursing facilities, inpatient rehabs, and LTACs. Back when they started to reform, it was a fill the beds type of environment. And all of a sudden, almost overnight, it turned into an empty the beds, get the patients out the door, move them back into the home. And that practice continues currently without fail, almost 20 years later. So CMS payment reforms changed the clinical behavior of physicians, nurses, and hospital paraprofessionals, and they changed the entire focus of hospital administrators and CFOs. The primary change, I think the easiest one to see that we all engage with and we witness on a daily basis, is how the payment methodology and the change in the payment structure changed the model of care from procedure, recovery, discharge to procedure, discharge, recovery. We see this and the evidence of this as our patients are being discharged home to us far more sick than we ever saw them before. And the beds were filled for on average of 13 days, 14 days under the procedure, recovery, discharge model. And now we look under the procedure, discharge, recovery model, and beds are filled for a matter of hours, often 24 to 36 hours instead of 13 to 14 days. CMS watched the development of this. They examined the innovations that were born of it, and they considered this a success in meeting their agenda. Sadly, and what makes me a little nervous, is CMS is convinced and thinks they understand that they have proof that placing quality before cost and quantity actually does succeed in producing better outcomes and reduced cost of care. Back in the day, as a nurse experiencing this change, I can tell you I didn't like it. Just like any other nurse, I put on my lion personality and I roared, and I dug in my heels, and I joined my peers on the picket line, marching up and down the sidewalk, protesting DRGs. and how it was going to kill patients and how it was going to just strip everything that we knew. And here we are today. DRGs are what define the entire content of the patient episode, not the clinicians providing the care. Nowhere in the Medicare certified acute care continuum does a nurse walk up to a hospital administrator and demand the patient stay an extra day or two. This just doesn't happen. Medicare Home Health is the only Medicare certified provider of care who sends one person by themselves into a home with no support, accountability, and they do this to determine the acuity, case mix, outcomes development, revenue integrity, develop a care plan, and then assign a visit frequency, cycle, and duration without any support whatsoever. This is how we've been operating the past 20 years. CMS sees it. They see our data. They read our documentation. They actually have a fair idea of what we do. And this is what they're now saying, we're no longer going to embrace this. So the care delivered in the acute care venue is data-driven in every respect. The data is developed by a team during the assessment process. Utilization review and services to be delivered are strictly governed by a utilization review team, which is a centralized group who authorizes best practice, cookie-cutter type care, which is then carried out by the clinical team and adjusted and molded to the unique individual aspects of the patient's disease in direct relationship to the severity of the illness and injury of the patient. Home health agencies wishing to continue to do business with CMS will soon learn how to do this and mimic the hospitals, or they'll lose market share as their competitors learn these skills and surpass the quality metrics of those who cannot or will not embrace these new payment models. This is noteworthy because in home health, it's always been about the visits, instead of what takes place during the visit and what happens between the visits, during the episode, and over the course of the episode. CMS's intent is to create a payment model where the visit performed in home health is done so with an acuity comparable to the same type of visit performed in a skilled nursing facility, inpatient rehab, the long-term care hospitals. This, in many manners, will prove to be a significant challenge for providers who have embraced a volume instead of a value-based business. And if you go back to the early beginnings of the Medicare program, the Metropolitan Life Insurance Company were one of the groups of folks who embraced Medicare home health. Metropolitan Life was responsible to its policyholders, and they saw the strong potential to prolong life and delay paying on their death benefits. MetLife basically sought to limit the number of visits, and specifically, they sought to eliminate types of personal services offered, and the types of personal services that they were, quote, complaining about directly parallel today's home health aid visits. If you look at the metrics in service utilization, home health aid visits continue to be the #1 most frequently delivered service in home health. So continuing on, MetLife and other insurers found that providing more care, in essence, more visits, did not improve outcomes. MetLife sought to limit the number of visits and eliminate the types of personal services offered, and then they finally ultimately discontinued home nursing services, determining this to be unprofitable. During IPS, the number of visits per episode was in the high 50s to 60s, with many episodes having 70 or more visits. As IPS transitioned to PPS, the number of visits dropped down into the 30s and 40s, and with case mix rebasing over the past decade, today's average number of visits is somewhere in the 12 to 15 per episode range, with the average number of combined therapy visits for the past 15 years being approximately 7.24 to 7.6 visits. As we move towards HHGM and the 30-day episode being implemented in 2019, MedPAC estimates there will be considerably more LUPA episodes than we see today, and far fewer late episodes than we see today in the PPS payment model. This is their goal: enhanced outcomes, reduced costs. And as I talk to providers about HHGM, which we do routinely, a lot of them say we'll just double down on the recertifications to keep their cash flow. This doubling down is basically going to consolidate the data. And when you consolidate the data and the patterns of data start to be revealed, this presents an ADR and a ZPIC problem, which will actually be exponentially faster and easier for the ZPICs, the MACs, the RACs, the SMRCs, and the CERTs to audit. All of these Medicare contractors' activities are tied strictly and directly to data-driven patterning. This is explained very nicely in the Medicare Program Integrity Manuals. So those who are improperly recertifying patients and utilization that's outside of usual and customary in direct correlation to the acuity recorded and transmitted by the OASIS will find that their data is quickly compressed and that the ADRs and the audits will now be happening within 4 to 6 months instead of 12 to 18 months. And of course, if you look back to MetLife again, MetLife just said MetLife said this is not profitable. And when we talk to Blue Cross, Blue Shield, CMS, and PPO, HMO type providers, very quickly the first words coming out of their mouth are lots of visits, lots of money, no outcomes. And that is their complaint. So too many visits, too much cost, too few outcomes have driven us to where we are today. So let's move into present day. Very little continuity between hospital services and the acuity and the post-acute care segment. And this new HHVBP, value-based purchasing, and HHGM are designed to assure that payments for services made are correlated to the similar or same acuity levels in the setting of the entire Medicare certified continuum. In essence, if I have a therapy visit reimbursed in the inpatient rehab for $150, it would be expected that the patient and the money that I spent to perform that visit, that the patient would have relatively the same acuity as a patient in the home health agency. Home health agencies have routinely failed to meet this threshold, and this is one of the primary drivers behind removing therapy bonuses in the HHGM payment models. Couple this with an assess and treat mentality and care planning, which is done off of objective or subjective nursing assessments that does not parallel the acuity of hospitals, SNFs, or LTACs, where a high level of acuity is and a low level of maintenance or chronic care exists, we have a disparity. Quite often, these subjective assessments in the result in 2 to 3 visits per episode that are focused on low-tech, non-skilled items or interventions that really provided little benefit to the payer or the patient in general. CMS is describing this as waste. And then we move into what is now an obsolete 1 week 9 research pattern, and this type of care is rapidly being diminished because of HHVBP and the 30-day HHGM episode. The 1 week 9 research patterns are highly prevalent in more than 50% of the industry, as documented by ABT and Associates, and the better part of 70% of the episodes are now 3rd, 4th, and 5th episodes. This is not to say that we cannot perform these, it's just that they don't produce outcomes, therefore they don't produce bonuses. So if we look at our skilled care, in far too many instances, home health skilled care is being utilized when the OASIS data that you generate and submit demonstrates the patient is far more appropriate for ambulatory services. CMS describes that as abuse, and at times service utilization in episodes where ambulatory care is indicated is then coupled with very high levels of therapy utilization, which is actually medically unbelievable, and CMS describes that as upcoding, and upcoding which is then interpreted to be fraud. An example would be a clinical one, functional one patient where more than 90% of the OASIS questions are answered as 0, and then 20 physical therapy visits are put in, and a bonus is received. The 20 physical therapy visits, when 90% of the OASIS answers are marked as 0, is upcoding, and that is fraud, because CMS's definition of fraud is willful, wrongful misrepresentation of patient status. The representation of patient status was done through the data through the OASIS assessment. The upcoding was done through the extra visits. It did not correlate to the acuity. So, a substantial number of agencies over the past years have embraced what I call, what can I find that Medicare will pay for? This has fostered the assess and treat mentality, which is kind of a fishing expedition, and again results in care planning that keeps the patient dependent on the services of the clinical staff and the agency, rather than fostering independence and self-management of the disease process. So when we go back and we look at all of these items as a whole, these components created the volume versus value model. In the volume model, clinicians and patients are seemingly incentivized to fail, as a dependency on agency is created in lieu of independence and self-management. And please know, it's important to know that none of these alternative payment methods, HHVBP or HHGM, disallow the provision of chronic or maintenance care. Let me say this again. You are not being told that you cannot provide maintenance care, chronic care. To do so would go against every Supreme Court case endorsing such care. M.O. v. Sebelius, Duggan v. Bowen, Pendergast versus Levinson, and many others. Instead, just like the BID diabetic outlier care of days gone by, CMS has evaluated what is going on in the maintenance and chronic care models and simply has chosen not to financially reward it. If the primary care model your agency embraces does not transmit OASIS-based outcomes to CMS, you will soon find that your business model is irrelevant to those who pay your claims and those who refer your patients to you. Hospitals are under great pressure to refer to agencies with above average STARS ratings. We're routinely seeing people bumped off of the hospital referral list if their STARS ratings are 3.5 or below. The question that we're starting to see now is because of the MACRA and MIPS physician metrics, quality metrics for the physicians, how long will it be before physicians are going to be pressured to refer to home health agencies with at least 3.5, 4 to 5 stars? How is CMS going to pressure the physician referral source to say, we can't have you referring to people who don't produce quality? So let's take a look at the markers for success. Average daily census, the more the merrier, the larger the better. Length of stay, equal to or greater than 120 days. Therapy utilization literally drives the reimbursement of the agency. And recertification whenever possible due to falls, medications, what have you. Now, if the markers for success continue to be average daily census, high length of stay, and therapy utilization, we now need to reinvent ourselves to look more like the following. How many RAPs and finals are you submitting on a weekly basis? The submission of a RAP followed by a final generates outcomes. How many outcomes that can be recorded and attributed to you in a positive manner do you submit on a weekly basis? The average length of stay in excess of 58 days, let me say this again, an average length of stay in excess of 58 days demonstrates a higher than average cost of care. It also demonstrates an elevated beneficiary disbursement, and it makes the agency with this metric, just this one metric alone, a very poor candidate for hospital or ACO partnership. Length of stay in excess of 58 days starts to be the primary cause of beneficiary disbursement surveys and length of stay reviews by ZPICs and other CMS contractors. This is well described in the Medicare Program Integrity Manual. And Again, in order to generate outcomes, agencies must discharge and manage their census in the same manner as hospitals do by using their OASIS metrics during the start of care, resumption, and recertification time points exactly the same way hospitals use their DRG data during the admission, interim time points, and when a change of condition is noted. Hospitals that use their DRG data in this manner experience significantly more financial predictability. They're far more stable, and home health providers who shun this will continue to be on shaky ground. But those who learn this skill and embrace a cyclical rhythm of admission and discharge, growing their unduplicated census instead of their average daily census, are going to have financial rewards very similar to the early days of PPS. So again, let me go back. I don't want you to think that we're telling you not to engage in maintenance care. Everybody has the right to provide maintenance care, and you have the right to provide long-term, high-volume chronic care. CMS will not decline payment for this care as long as it is done within the Medicare guidelines. The payment, however, is tied to the acuity, the length of stay, and as you can see in these new payment models, the payment's going to be minimal, and it could actually become cost prohibitive. And again, it will be cost prohibitive because maintenance of something is far less expensive than complete restoration. Maintenance, again, is going to be allowed, but again, it does not generate the outcomes that are necessary to move forward and be successful. So let's talk about the future of MedPAC here. MedPAC, as previously mentioned, these payment models are designed to assure that payments for services approximate the same level of acuity across the entire Medicare certified continuum. Agencies who have traditionally depended on the 6, 14, and 20 visit therapy utilization bonuses, which seems to be well over 50% of the agencies that we've talked to, state that they cannot live without these bonuses. Well, guess what? It's time to learn how to finance operations without these extra payments. Quite honestly, this is easily done. It's not impossible. It does require a change in mindset and how you think. And the component that will lead you to success is real-time service utilization review and live quality assurance activities that are performed during the OASIS assessment while the nurse is in the home. These types of processes parallel hospital practices. Again, service utilization review, when coupled with live QA, activities produce profits that really truly predictably parallel the early days of the PPS payment model. If you're in control of your clinical programming at a centralized location and you utilize data-driven metrics to do your staffing, frequency, cycle, and durations, there's absolutely no reason that you don't have a nice profit margin. So live interactive QA during the OASIS assessment will maximize your reimbursement, assure your revenue integrity, and establish the ability to perform a meaningful service utilization review. Again, one of the things that Medicare looked at with the hospitals is how did they develop efficiencies, and the live QA interaction and the interactive OASIS assessment actually breaks the dysfunctional cycle and the back and forth cyclical quality assurance tasks, cross this T, dot that I, etc. And this is one of the primary ways that people are gaining efficiencies. So more than over, agency owners are going to depend on the sophistication of their internal and external care team's ability to develop their acuity and their reimbursement. So no longer, and I'm sorry, I got ahead with one slide here, so no longer is the completion and return of an OASIS assessment to the office in 8 to 12 hours sufficient. OASIS being turned into the office 8 to 12 hours, and which that sounds like a dream to some of you, is simply not going to be adequate. If you're 24 to 36 hours waiting on your OASIS, you're losing probably $300 to $500 in efficiency and revenue. So if you look at this new HHGM grouper, and as it's rolled out, more than 50% of the clinicians demonstrate difficulty just with the C2 grouper. Every time the C2 grouper is updated, there's a 90 to 120-day ripple effect of lack of understanding, getting up to speed, so to speak, and more than 50% of the clinicians have a hard time with that. As we move into HHGM, in the first year of HHGM, it's predicted that more than 90% of the clinicians are going to require significant assistance just to be able to get the OASIS and the new assessment done in order to be able to afford the care that your patients need. This back and forth cyclical process easily eats up 20 to 25% of the care window opportunity and your ability to influence patient care. So let's talk about why HHGM is viable in the eyes of CMS. CMS and their consultants looked at the compilation of clinical visits over the stratum of 60 days. More than 50% of the second 30 days of an episode had the least amount of visits. So almost all of the visits are during the first 30 days. This is a byproduct of the quality improvement networks and the quality improvement organizations to push the front loading of visits to reduce hospitalizations, keeping patients out of the hospital for at least 30 days. If we look at the ABT and Associates, Mathematica Research, RTI, and the other consultants that advise MedPAC, it is well documented that the majority, 70% of all episodes, are late episodes. That means 6 months or longer length of stay. This is why the second, third, fourth, fifth episodes in the HHGM model are dropping reimbursement. Again, there's a data-driven micromanagement system going into this that basically turns us on our ear saying, okay, move as many of them as you can through, and then those who you wish to keep as maintenance, you're going to have to figure out how to do so in a very tight and stringent budget. So again, our referral source is going to dictate payment. Early versus late will dictate payment. There are many things affecting payment that will be tied to how the OASIS is performed and the different metrics that you gather and report. So moving into the future here, if you don't have an acute care provider or an ACO as a referral source, chances are you're already feeling the pain. These people are going to control the flow of patients. And again, the community referral is going to be reimbursed differently than the hospital or the ACO referral. We're going to probably see a little bit more hospital-like staffing. We're already seeing noon to 9 shifts, and we're seeing quite a few 7 days a week. Agencies who are wildly successful are able to basically perform an OASIS assessment within 4 to 8 hours of referral. We're seeing this more and more now. Rapid cycle response to referrals, getting nurses out to homes, and of course the majority of this is done in an acuity base. So sick patients get the rapid response. Those who can wait a little longer will have the next day response. All OASIS assessments and quality assurance and service utilization review will be done in concert while the nurse is in the home in real time. The level of accuracy required to navigate the new PPS grouper models, and think of this, the last 10 years, every single year the grouper has changed, the case mix has dropped, the reimbursement has dropped, and it's much harder to get a good acuity. This is really forcing us now to move the assessment and quality assurance activities into the home during the real-time admission. After we get that done, our care plan needs to be initiated during the start of care visit with goals expected to be reached before the first follow-up visit. Again, you'll see in this 30-day payment model where the majority of care plans are going to be 6 visits, with a fair amount of these care plans being LUPAs. Again, utilization will be based on OASIS acuity data. Our number one complaint about the HMO PPO model is that they don't get enough visits. And quite honestly, if you look at the HMO PPO business model, And the reality of it is their patients seem to do okay for the most part. So this is where we're now going to be transitioning into rapid cycle, unduplicated census that produces a turnover. We're already seeing some of our clients who have a 30-day length of stay or less. Agencies who get into lengths of stays that are 40, 42 days all of a sudden realize that the overhead of carrying a large volume census is actually responsible for sinking them financially. Maintaining a large census is very expensive. So as we reduce our length of stay, and some of our clients are actually 26, 28 days, and their margins are incredible, we're going to see this trend moving forward. And of course then, there's no longer reliance on therapy income. And if we're going to provide therapy services, we're going to get this assessment right. Recertifications will probably be rare. They'll be there. But they're something that's not going to enhance your business profile. They're going to take away from your outcomes. So just by the nature of the way things are bonused and worked with, we're not going to see as many recertifications. People will be more hesitant. And then LUPAs are expected to be very common. So let's talk about some of the practical steps to begin a successful change in the industry. I know this is nerve-wracking, and it'll make you pull your hairs, but there's a right way, and a right way, as long as we get to the final destination. Some of the hospitals that we're seeing in Texas now are actually requiring behavioral readmission contracts with the patients they discharge to the community. If home health was part of the discharge plan and the patients refuse the home health services, they're out of compliance. If patients refuse to comply with their medications and diet restrictions that are given to them, they're out of compliance. CMS and the intermediaries that pay your claims feel that they have the right to expect patients and patients' caregivers to comply with the care plans developed, implemented, and executed by contractors, you, hospitals, SNFs, and they start to look at us and say, you know, we should have the ability to assume, the patients should be able to assume responsibility for self-care. And we all know there's two classes of patients in here, so let's talk about this. Patients who refuse to comply with best practices established by the quality improvement networks, quality improvement organizations, actually do damage your star ratings, and they damage your outcomes. This is what the hospitals are focused on, and this is why the hospitals are now taking a strong stance saying you must comply, because they're financially penalized. So patients who refuse to comply do damage your star ratings, increase your cost of care, making you a poor choice for other business partner. They increase your length of stay, and they jeopardize your continued contracting with Medicare. Those who are fully unable to comply are a completely different story. They obviously need special accommodations and additional or alternative services, and differentiating between those who can and cannot move forward and assume responsibility for their own care is part of what we're going to be doing during the start of care and recertification visits. To this end, documented patient goals and field staff accountability, assuring that these goals are met, is essential. Walking in, spending 20 minutes, sprinkling a little fairy dust, having tea and vital signs and crumpets with the patient is simply not going to happen anymore. We also need to take accountability for how the OASIS assessment was performed in the home. We've devised a fantastic way of 100% of the time understanding how the assessment was done, and we'll explain that a little bit later. But if you can't assure that a walking OASIS assessment was done, walking to every room, transferring off of the couch, off of the chair, getting up and down from the kitchen table, possibly reaching in and out of cupboards, and demonstrating the ability to at least put shoes and socks on, we're not getting the acuity we need. So getting this acuity in a standardized, efficient manner will also increase productivity. This is something that is directly related to the cost of care, which again is going to be our next performance metric to conquer. 5-star outcomes are important, but it's going to become cost of care after that. Remember, the hospitals had to produce quality first, and then about 4 to 5 years after the acute care reforms started, it became quality plus cost of care. Most of us have not even scratched the surface of trying to move forward with efficiency and controlling our cost of care. And let's be honest, the reason for this is today's agencies are managed, controlled, and positioned for success by really well-intentioned clinicians who are running around town in their Corollas or the passenger seats full of fast food wrappers because, well, let's be honest, getting lunch is often just catching a whiff of the French fries at the local burger stand and calling that lunch. Then these fantastic people who work like bandits and do amazing things tell you what you're going to do with the income that they generated. And then some of them, when you challenge them, will just look at you and say, you know, you're darn lucky to have me. So it's the privilege of paying to do this. The other thing we hear is, you have no idea of what we do. But we do. We see your data, we read your clinical notes, and CMS does the same. And this is where the state of surveyors and medical review personnel look at stuff and say, it's time for change. So the agency with the future is going to centralize all clinical programming. They're not going to let 40 or 50 nurses go out and do, quote, their own thing, because that's 40 or 50 different methodologies. And yes, you can have an EMR that guides them and structures things. The hospitals had that as well, and they quickly abandoned it. So the agency of the future is going to centralize and consolidate all clinical programming activities, just as the hospitals, the SNFs, and the IRFs do. Once it is centralized and coupled with live QA services and service utilization review, you'll have a completely different feel and look to your agency. And honestly, if the hospitals and their other parallel partners found this to be ineffective, chances are they would have abandoned this stuff 20 years ago. Now, when we talk about QAPI, service utilization, data-driven length of stay, and outcomes, please realize that the history of your business is written in your data. And the future of all Medicare contractors is understanding how to use that data to meet their program mandates as established by CMS. Whether that be reducing errant billing rates, identifying immediate jeopardy situations, data mining to find financial sanctions during surveys, or simply using your data in the data-driven survey protocols, every agency with their quality assurance process improvement must stop reacting to data that they have, 30, 60, or 90-day-old data, and start focusing on the creation and control and the ethical manipulation of the data to the positive outcome of the agency and the patient. If you're simply benchmarking yourself against the average, when CMS has made it very clear that average is no longer good enough, the only choice you have left is to create your data during the assessments, and that is done with centralized programming, centralized assessments, and standardization of assessment practice. To this end, if you look at the Pepper reports, they're great, but there's a problem. They do not provide granular detailed information, and even if they did provide granular detailed information, we'd need a fresh copy of these things every 30 days to be able to track and trend where we're at and what's going on. And again, CASPER reports are very valuable, and there's 125 metrics in them that I look at in retrospect, but we actually focus on the creation of those 125 metrics far more than we do on reading and reacting to them. And again, the latency of this data puts you in a reactive versus proactive mode. If you look at hospitals, you look at their other parallel partners, SNFs and LTACs, they are in the business of creating data and then evaluating how it worked. That way, the creation cycle is much easier to tweak than completely reinventing something every 90 days. So again, create your data or react to your data. You're going to be doing one, but the creation of your data during the assessment with your centralized care planning and your utilization review is far more cost effective. At that point, you can actually control the labor costs. When it's retrospective, the money's already gone. And again, one more time, service utilization review must be done during the start of care visit, not afterwards. QAPI, getting it right at the start of care. Again, we had talked earlier that every time there's a change in the PPS grouper or OASIS questions, there's a ripple effect that's seen. And that goes on for 90 to 120 days as clinicians begin to get used to these new metrics. The most common errors we see are in the cognitive domains and how those interact and affect the patient's ability to safely perform IADLs and ADLs. So we need to basically take a look at our M questions, make sure we get them right, and adjust what's going on in service utilization for episode timing. And therapy utilization is something that we're always going to have to deal with. Remember, nurses are wired to take care of patients, not to babysit computers. And if the success of your agency is important to you, work with the nurses to alleviate all this draconian EMR documentation that happens after hours. In the hospital, we work shoulder to shoulder, side by side, and we left no one behind. In home health, we send amazing people to perform tasks that no other Medicare certified entity would ever consider doing. And then we second guess them, ask them to correct things, cross the T, dot the I, and we go back and forth in this cyclical cycle of dysfunction. And then we wonder why we have burnout, recruitment and retention issues, and we wonder why we have audits and ADRs. QAPI is something that has to be done right at the start of care. So again, you can see our scribing process here, where our nurse has no computer between her and the patient, and the nurse is literally talking to the scribe in the office, who's working in the office's EMR, and entering the data as collected and then relayed by the nurse to the scribe. This eliminates the need for back and forth corrections. It really does break this adversarial loop that goes on between the QA department and everybody else. And at this point, it reduces the charting time, allowing the nurse to walk out of the home with no paperwork to do. This is realizing new levels of efficiencies, and it's going to be critical in your success moving forward. Again, closing the laptop, removing the paper, focusing on the patient without that huge pressure of all this paperwork left to do is going to change the life of your nurse, the life of your internal office, and it benefits the patient and your agency. Software-assisted scribing will literally change your life here. So again, as service utilization review, examples, functional 1 does not equal 20 therapy visits. Clinical 3 levels require more skilled nursing visits than clinical 2 levels. And clinical 1, functional 1 is probably going to be a LUPA. These things need to be determined during the start of care while the nurse is in the home with the patient. Your internal office staff is capable of generating and running the data once they get the answers from the nurse. And again, this is the type of approach that parallels hospitals who already went through these reforms 20 years ago. So break down the barriers to care, make things more efficiency, and when you're looking at functional 1, clinical 1, and you're adding 20 therapy visits, please stop and consider what you're doing, or are you considering these scores in relationship? All of the OASIS data, the HIPs, the HRGs, the treatment authorization codes, and the M items have a specific purpose. All 4 components of this data, specifically the 15-digit treatment authorization code, are designed to interact with the 5 CMS software systems that you've never seen behind the scene. Oscar, Odie, Aspen, Plato, STARS, all of those things interact with the OASIS data to produce reports that contractors use. If the contractors use the data, why don't we? Your length of stay and your service utilization must be based on your start of care or recertification OASIS acuity. This then stops the subjective seems right, feels right recertification process, and then you'll be into data-driven care in the same manner that hospitals are. So in our primary diagnosis and the confusion that we see, are these questions in 45 Locator 21 answered? Can you tell by looking only at Locator 1, what is the diagnosis? Which interventions will keep this patient out of the hospital? Which of these interventions are prioritized, the most important? Which should be taught first? And when do I anticipate discharge, if ever? So how does this care plan ensure I meet my outcomes? And let me just give you the last two slides here, because this is what we're seeing over and over and over. This is present care planning. Can you tell me what the diagnosis of this patient is? And I'm going to stop real quick and say it's a rhetorical question because I cannot figure out for the life of me what the diagnosis is here. Can you tell me what I'm supposed to do first? Which one of these interventions is going to demonstrate outcomes? And how do I manage my patient's length of stay here? If I'm a doctor, I'm really hesitant to sign it. If I'm a clinician, I take one look at this and I have no guidance. So as we do our service utilization review during the start of care, and the nurse in the home and the quality assurance department in the office work together, we now have the ability to produce a diagnosis-based care plan. And we're going to show you a 30-day care plan here because, quite honestly, we're preparing all of our clients for HHGM. So if we have our cookie cutter care plan, which everybody calls cookie cutter, we're able to start here. And if we need to add one or two minor interventions into a visit, we can do this. But this is what the quality improvement networks have put forth. This is actually a care plan from a quality improvement network. And the quality improvement networks are very focused on what goes on during the visit, what happens between the visit, not the number of visits performed. And this does go against the grain of what we've been doing the last 20 years, but what we've been doing the last 20 years is simply not going to be reimbursed anymore. So, as I end here, realize the hospital DRG model changed the entire care delivery model from procedure, recovery, discharge to procedure, discharge, recovery. Hospitals, who are arguably much stronger than most of us, have much more political clout, much more lobbying clout, and probably more expensive lawyers than most of us, were unable to stop these changes, and their length of stay went from 10 days to 3 days on average. Controlled labor costs with better outcomes, well, that was pretty much going to happen just the way things were reimbursed. And then specific concentration was on the reason for admission as far as treatment. There was no fishing expedition. What I came in for as a primary diagnosis is what was treated, and I was released. If I came back 2-3 weeks later with something else, that's a different thing. Our home health grouper model is going to decrease our length of stay. And in the home health grouper model, we're incentivized to empower patients to manage their own chronic conditions, not be dependent upon the home health agency. We're going to control our costs within the 30-day episodes. Those who have no control over how the assessment is done in the home or cannot get it back in 4 to 6 hours are going to suffer greatly. And then in the HHGM model, the HHVBP model, and is moving forward in general, we need to focus on the referral diagnosis, probably the comorbidities that are out of control, but our 20-year history of going on fishing expeditions is most likely going to come to an end. So with all of that jabbering, I hope I haven't put anybody to sleep, and I absolutely thank you for attending. Does anybody have any questions? And Robert, I'll turn this back to you.
Yeah, we do have a number of questions that have come in. Just a couple things. I think the number one question, my mic is on, right, Michael? You can hear me?
Mm-hmm. I can hear you.
Great. Well, the number one question is this being recorded? I want to share it with my staff. So, and I just wanted to let everyone know that, yes, indeed, we're recording, and we will be sending out a link to the recording likely within 48 hours. So we do have a few questions, and I'll go ahead and just ask to the first one. Earlier on, you talked about the future models of care, and someone was thrown off the start of care. Did you mean 48 hours from referral to start of care, or 4 to 8 hours before start of care?
4 to 8 hours to get a start of care. A fair amount of our clients are now responding within 4 to 8 hours and actually bringing a claim to a wrap-ready status before the end of the day. So if they get a referral at 9 o'clock in the morning, they're out by 1 o'clock in the afternoon, and the care plan is returned to the referral source and the wrap is dropped by 5 p.m. That is becoming a common profile with the folks we work with.
I had another question here. You touched on centralizing the process of QA especially. Who would be doing the scribing in your model that you had mentioned on that slide? Could you elaborate on that just a little bit?
Sure. The nice thing about scribing is it takes your existing resources, your existing software, and your existing personnel, and all it does is reorganize when tasks are done with a very minimal disruption to how tasks are done. To go a little further, most quality assurance activities take place 3 to 4 to 5 days after the OASIS visit, and that takes about 7 to 10 hours total time. The scribe model front loads, just like we do with the sick patient, front loads all of the QA live into the assessment process, reducing the time from the start of care to the wrap submission to about 3 hours. Does that answer the question?
So this centralized scribe works with assigned care teams, perhaps, something like that. They're assigned different intake nurses, lays in teams.
Every agency seems to be a little bit different, and we've implemented at least a dozen different variations dependent on the type of medical EMR they use, the number of staff they have, the number of OASIS they have. There's always other things like cell phone issues that are available, after hours stuff. All of these are simply logistics that are easily worked through, but they have to be thoughtfully worked through.
Mm-hmm. And another question on that same topic. Follow-up visits, do you still use scribes, or is that for the start of care only?
Completely agency determined. An agency can use scribes for everything, or an agency can use scribes only for the most important. The process of scribing is a very fluid, flexible thing that, again, you get to do it the way you want to do it, as long as it becomes producing the effective results that you're looking for. There's no set rules for scribing. With that said, Joint Commission, CGS, Palmetto, and NGS have all chimed in on the use of scribes, and they have no problem with it.
Okay. Do you find that visits are longer than in this model, the new model of care? I think you touched on that.
Actually, no. Actually, no. We find the visits are shorter, far more accurate, much more concise. The only problem we had is one of our clients in Las Vegas, her husband went into the office and asked why she had been terminated because she hadn't opened up her computer for the entire week when she got home. So this does eliminate the after-hours documentation in a dramatic way.
Gotcha. So Michael, I'm getting just a number of specific questions around this, and what I'm wondering is, I'm not sure if you or Carl would be willing to entertain email questions. Is that a possibility? If we don't get to all of them?
Not a problem.
Would you mind?
Not a problem. And it sounds like we might need to do a webinar on scribing.
You know, that might be a possibility. Before we put up Michael's email again here, you're going to be inundated, Michael. I did want to mention on the next slide, actually, would you mind just going forward to one more? There we go. So do you mind sharing this right here with this special offer that you are doing?
No problem. Do you want me to describe it?
Yes, please.
Okay. What we do is we utilize CMS contractors metrics that are not known in the general public. I used to work for CMS. I used to work on those platforms. So we're offering to the first 10 agencies a ZPIC, VBP, HHGM risk assessment, which is running 12 months worth of your data, giving you the reports and reviewing them with you via WebEx. Agencies find out the level of unsustainable income that they have and then immediately start to remediate and make their lives better. So it's through Devero, they twisted our arm and we happily complied with their request to do this.
Well, we like to add value to those folks who join our webinars, and this is a great value. We appreciate your knowledge. Maybe just a couple of scribe-based questions, if you wouldn't mind.
Sure.
So in this model, if you had, say, a 200 patient census, say 25 clinicians, how many scribes would you estimate would be required in this model?
Okay, the question demonstrates old school thinking, number one, because census is no longer the measure of success, outcomes are. The question should be, how many OASIS events do you do per day? And then you're able to determine your staffing needs. Remember, this is empty the beds, not fill the beds. So on average, we're finding that a scribe can do 5 to 6 OASIS assessments per day, and we're finding in all practicality that most nurses are now doing 5 OASIS assessments per day without any documentation after 5:30 p.m., and that is the norm. Occasionally they'll get 6, but where nurses have normally been doing 3, they're now doing 4 to 5, increasing the capacity for care, and that increase in capacity reduces the cost of care. More patients, same staff, more revenue, same staff. You can see the inversion starting to take place.
Interesting. Well, I'll tell you what. To those, I'm being inundated with emails right now, and and I appreciate the questions. And to those of you who are sending me questions, and most of them seem to be about the recording, which is a good sign. I think people enjoyed the presentation, Michael. Michael's email is up there, and if your question was not answered, feel free to ping him. If is that okay, Michael? And maybe if you could forward.
It's okay. If we have 300 emails, please bear with me. It might take a day or so to get back to you.
Or maybe Christy can help offset some of the questions there. I think what I'd like to do then is, I'll leave Michael's information up here. For those of you who attended, we will be sending out a recording of this webinar, and I did want to ask a special favor for those of you who are attending. We really like to speak to the topics that are of concern to the agencies that are clients of ours, as well as those out in the industry at large. And we did a little survey, and I'm hoping I'm going to send this out through email. I'm also going to put it in the chat pane here. If those of you who are on the line could just do me a favor and do this 10-question survey that's going to help us identify key issues of concern for your organization. That'll help us shape these webinars and content that we produce in the future. And it sounds, if you were able to click on this webinar, that would be fantastic. And it does sound like folks really want you back, Michael, for another follow-up webinar. I think we're going to have to talk about that.
Happy to do so. It's a confusing, scary time that has literally got a lot of practical, easy to implement solutions. We just have to think outside the box.
And we appreciate the voice of sanity in these uncertain times, because there are a lot of scary messages out there, and it sounds like change is coming, even if things do get delayed for periods of time. It's inevitable, it sounds, and we need to be prepared.
Life will go on, and we will all survive.
Well, Michael, thank you very much, and Christy on the line as well, and Carl for pulling this together, and thanks to everybody who's on the line today. We will be sending you a little bit of information from Michael's company, OperaCare, And just a little thank you from Devero here. Again, Devero and NetSmart are the sponsors of the webinar series, and we appreciate you attending. Follow-up recording is coming your way. If you have questions, you can email me, the person who set up the webinar. This is Robert Love. You can email Michael McGowan, whose email is on the screen. Please take the survey, and thanks everybody for joining us today, and I hope you enjoyed the presentation. Have a great day.